Great. Thank you so much, Maya. Welcome, everybody. I'm introducing Tatyana Milman, who is currently a professor of ophthalmology and pathology at Thomas Jefferson University and Wills Eye Hospital in Philadelphia. She's certified by the American Boards of Ophthalmology and Pathology, and her research interests include clinical pathologic correlations in ophthalmic pathology and resident education. Dr. Milman has over 100 published peer-reviewed articles and has contributed chapters to several key volumes in the field of eye pathology, including the WHO classification, ARP, AFIP fascicles on the tumors of the eye and ocular adnexa, Albert and Jacobi's principles of and practice of ophthalmology, and Duane ophthalmology. Dr. Milman currently serves as a lead author of the College of American Pathology Cancer Protocols on uveal melanoma and retinoblastoma. She has been awarded certificates of appreciation from the American Academy of Ophthalmology and the American Board of Ophthalmology for her service in various committees dedicated to maintenance of certification and education in ophthalmology and ophthalmic pathology. Most recently, in 2020, she received a Senior Achievement Award from the American Academy of Ophthalmology. She is a recipient of numerous ophthalmology resident teaching awards for her instruction in ophthalmic pathology. Dr. Milman is a member of the American Ophthalmic Society and Eastern and Verhoef-Zimmermann Ophthalmic Pathology Societies, and serves on the board of the American Association of Ophthalmic Oncologists and Pathologists. Welcome, Dr. Milman.
Thank you very much. It's an honor and a pleasure to be able to share with you my experience in eye pathology. Hopefully, the attendees will find this useful. So I'm going to share my screen and we'll proceed with the first part, which will be in PowerPoint lecture format. And then we'll hopefully consolidate what we learned with a virtual slide session. Let me see. I'm going to open the chat window. So if attendees have any questions or comments, please feel free to use the chat window. And if there is any way to unmute and speak, please go ahead. As I have no financial relationships to disclose, as was already mentioned, the goals of today's discussion will be to classify key corneal dystrophies, identify pertinent clinical and pathologic features of those dystrophies, and try to formulate a differential diagnosis that will help distinguish these dystrophies from other masquerading lesions. Before we jump into pathology, let's very quickly review normal histology of the cornea. Many of you are familiar with it, but it's good to have a good basis before we look at pathology. So cornea is surfaced by the epithelium, which is usually 5 cell layers thick. It's stratified squamous non-keratinizing epithelium. No goblet cells are normally present. It rests on a very delicate basement membrane that is difficult to appreciate on this magnification, which in turn rests on an acellular Bowman membrane or Bowman's layer, which can be thought of as a condensation of corneal stroma. Corneal stroma is composed of evenly sized, evenly spaced collagen bundles arranged in lamellae. And this uniform arrangement contributes to transparency of the cornea. You can see here that the bundles are separated by clear, empty-looking clefts. This is an artifact of dehydration and processing. It is not present in normal tissue, but it is a meaningful artifact. When we lose this evenness of lamellae and crispness, that suggests that there is either edema or fibrosis or deposits in the corneal stroma. Also know that there are spindle cells within the stroma, and those are corneal resident fibroblasts or keratocytes. Beneath stroma, there is Descemet's membrane. It's usually uniform in thickness, and it becomes thicker and thicker with age, since this is a basement membrane deposited by corneal endothelium, which is a monolayer of hexagonal cells that function as a pump to pump the fluid out from the cornea. And that's another reason why cornea is transparent. When endothelial integrity is compromised, edema occurs. This is higher magnification photomicrograph that highlights for you regularly arranged collagen bundles with lamellar architecture, keratocytes, decimase membrane, and a monolayer of endothelium. There is this acellular, very delicate collagenous stromal layer right before decimase membrane that has gained increased importance lately as endothelial keratoplasty procedures are done, and it's called by many clinicians Duo's layer. This is scanning electron micrograph that highlights for you the orientation of endothelium, decimase membrane, and stroma. So in eye pathology, as you may know, we use PS stain very liberally, similarly to renal pathology, because it highlights basement membranes and other pathologies. Here you can see normal epithelial basement membrane, even and thin, and Bowman's layer does not stain, not being a true basement membrane. In contrast, we can see the decimase membrane stains with PS being a true basement membrane deposited by endothelium. So we talked about collagen arrangement, endothelium pump that contribute to transparency of the cornea. Avascularity is yet another reason why cornea is transparent. You can see here the junction between cornea and sclera and limbal vasculature, which provides one of the sources of nutrition by diffusion into the cornea. You can also appreciate that corneal collagen lamellae are even in size and arrangement, and in contrast, scleral collagen is coarser, unevenly sized, and that's one of the reasons why sclera is opaque. So now let's jump into the dystrophies. And in the past, dystrophies have been categorized anatomically based on the tissue that they affect. Nowadays, we embrace our colleagues' classification schemes, such as neuropathology, and we try to create an integrated clinical and molecular or anatomic and molecular classification of these dystrophies. Our most current go-to reference is this, the IC3D classification of corneal dystrophies, which provides a clinical, pathologic, molecular correlation and gives us an idea of the relevance. Give me 1 second to come up with the appropriate name. Gives us an idea of the strength of evidence for assigning the term dystrophy to the process based on the known molecular information and inheritance pattern. So typically dystrophies are bilateral, although they can be asymmetric. They occur in young patients. They are frequently central as opposed to peripheral. And by definition, there has to be an inherited genetic defect. However, interestingly, in many dystrophies, pathology only manifests in the cornea, even though autosomal, you may expect a germline mutation in many of these conditions. So these criteria help distinguish dystrophies from other processes that can involve cornea, such as degenerations. So let's talk first about epithelial and subepithelial dystrophies that primarily manifest in these anatomic regions of the cornea. And the most common ones are itemized in this slide. The first three ones share clinical and pathologic features, and therefore I will discuss them as a group to highlight the overlap between these three conditions and to help you distinguish one from the other. So let's first talk about Milman dystrophy, which is primarily confined to the epithelium. It manifests early in life with vacuoles within corneal epithelium that can be highlighted with retroillumination. That's a technique in which clinician is going to shine the light into the eye and corneal opacities are highlighted as the light is reflected from the back of the fundus. Another technique that some clinicians will use is confocal microscopy that can also look at corneal pathology. As most corneal dystrophies, it's autosomal dominant and it's caused by mutation of the cornea-specific keratin genes that encode keratin 3 and keratin 12, and they're involved in cytoskeleton of the corneal epithelium. What is happening in Milman dystrophy is abnormality in corneal epithelial shape. You can see that epithelium is really pleomorphic. Each individual cell is pleomorphic. And epithelial cells acquire this vacuolated cytoplasm appearance, degenerate to form cysts and clinically apparent vacuoles. As a secondary phenomenon, there is thickened epithelial basement membrane. This vacuolated material within the cytoplasm is going to stain with PES stain. And most of this material does not digest with diastase because it's an abnormal cytokeratin aggregate. And in the past, before we knew that it was cytokeratin, it was called peculiar substance ultrastructurally. There is also some glycogen accumulating as well, and that will digest with diastase. You can also see how PS highlights the basement membrane of the epithelium that's thickened. Now, Lisch dystrophy, another dystrophy that is primarily confined to the corneal epithelium, has been linked to a locus on chromosome X, and it's inherited in X-linked dominant fashion. There is no specific gene that has been so far identified, and clinically, what you see is a junction between normal cornea and this feathery, opaque epithelium. Similar junction between normal and affected cornea can be seen histologically, so that's what you look for. Note that epithelial cells are similarly vacuolated to what you saw in Milman dystrophy, although there is not such a range of abnormalities in shape. And also note that there is no appreciable thickening of epithelial basement membrane, and basal epithelial cells are relatively normal. PES stain here does not show exuberant PS positive material, and whatever is present is glycogen, which will digest with diastase. And ultrastructurally, you see intracytoplasmic empty vacuoles. In the past, researchers suggested there is some sort of a lipoprotein that accumulates in the cytoplasm of the cells, but we actually don't know what causes vacuolation here. And last but not least, probably most importantly, epithelial basement membrane dystrophy, also known by other names such as Map-dot-fingerprint of a dystrophy, rarely can be documented to have autosomal dominant inheritance, in which case these cases are linked to TGFBI gene mutations, transforming growth factor beta inducible gene that you will hear about in a little bit. However, most cases are sporadic. And in most cases, most often than not, you're going to see this as a secondary degenerative process, as opposed to a dystrophic process, which requires very careful clinical pathological correlation to parcel out what's exactly going on. So what you expect to find in epithelial basement membrane dystrophy are these opacities at the level of basement membrane and epithelium that manifest as fingerprint-like lines, microcysts or dots, and geographic map lines. And what is happening here is pathology that's at the level of basement membrane. And what you're looking here is a specimen from superficial keratectomy that was done to induce normal epithelium with to grow over the cornea in a more adherent fashion to prevent recurrent erosions or disformation of the epithelium that can be painful to the patient. So that's why the tissue is so folded. So pathology here, as I mentioned, is at the level of basement membrane, where you see focal thickening of the epithelium with intraepithelial basement membrane formation and epithelial reduplication. And what's happening here is as epithelium separates with its basement membrane from underlying Bowman's layer because of poor adhesion, the epithelial cells grow into the cleft from the edges, causing 2 layers of epithelium with basement membrane sandwiched in the middle. Also, as epithelial cells are poorly adherent to the underlying Bowman's layer, they will desquamate, forming microcysts. So these alterations clinically manifest as dots, geographic map lines, and fingerprints. Note that epithelial cells themselves here are morphologically normal, unlike those in Milman dystrophy and Lisch dystrophy. There is no cytoplasmic vacuolation. There is no cytoplasmic PS positive material. And the last epithelial dystrophy that I will discuss here is gelatinous droplet dystrophy. And you can see why it has its name, because of these subepithelial gelatinous nodules. Unlike most corneal dystrophies, it's inherited in a recessive fashion. And as a rule of thumb, recessive dystrophies are most visually impairing. It's caused by mutation in tumor-associated calcium signal transducer 2 gene. And even though many patients will present with these gelatinous lesions, it can actually have a range of manifestations with band keratopathy-like findings, as you can see in the middle, and yellowish kumquat lesions, as you can see on your right. And histologically, you will see amyloid in subepithelial distribution. This amyloid will stain with Congo red stain, as you may expect, and will demonstrate characteristic pattern of polarization. This amyloid will stain with antibodies to lactoferrin. And this dystrophy, as I mentioned, is really visually impairing. It recurs almost invariably and rapidly following any kind of surgical manipulation. I have seen personally perhaps 10 specimens with this dystrophy. All of them have come from a single patient. Kind of highlights to you how rare it is, but yet how impairing. So here you can see this dystrophy recurring subepithelially and along the suture track of a failed penetrating keratoplastic graft. Now, going deeper, epithelial stromal TGFBI dystrophies are grouped based on the underlying genetic defect, and that's transforming growth factor beta inducible gene mutation that encodes keratoepithelium, an extracellular matrix protein that's produced predominantly in an adult eye by corneal epithelium and to a lesser extent by activated keratocytes. So resting normal keratocytes in the cornea generally do not produce this protein. And its function is not completely understood, but presumably it functions in cell attachment, migration, and interactions between cells and matrix. What happens here is that mutation in TGFBI gene causes this protein deposit in the cornea, in the epithelium, along Bowman's layer, in the stroma. And depending on where mutation is present within the gene, you have a different phenotype. And all of these dystrophies are caused by TGFBI gene mutations. So we're going to go now anatomically from anterior to posterior. The first two dystrophies primarily manifest at the level of Bowman's layer, and these are Reese-Buechler's and Thiel-Danke dystrophies. Reese-Buechler dystrophy classically has these more granular looking deposits. And what you're seeing here histologically is diffuse loss of Bowman's layer. Its replacement by fibrous collagenous panis that contains these intensely eosinophilic, granular looking deposits. Also note that the overlying epithelium has this jagged posterior edge, which is called sawtoothing. And even though primary pathology is at the level of Bowman's layer, there are similar deposits and deeper stroma. Here you can see anterior lamellar keratoplasty. Note that the surgeon removed only anterior portion of the cornea, which tells you that pathology was anterior. And we see that these deposits stain with Mason trichrome stain. These are called hyaline by ophthalmic pathologists. It's a descriptive term. What we are really seeing here is mutant TGFBI protein or keratoepithelium. These deposits also have characteristic ultrastructural features, but almost no one does EM anymore for these conditions. Genetic testing really supplanted ultrastructural studies. Again, morphologically similar dystrophy that in the past was confused with Reese-Buechler is Thiel-Danke. And again, here we have the same TGFBI gene defect, but in a different mutation. Very similar morphologic features. The deposits perhaps are not as Mason trichrome positive, perhaps not as sharply demarcated, but again, they will stain with keratoepithelium antibodies, and ultrastructurally, you have curly filaments at the level of Bowman's layer, which is mutant keratoepithelium. Going deeper, granular corneal dystrophy type 1, again, the same gene, same deposits as in Reese-Buechler's dystrophy, except deeper stroma rather than Bowman's layer is predominantly affected. And these have very sharp outlines separated by clear cornea, and you can see the same finding pathologically, very sharply demarcated eosinophilic deposits separated by uninvolved stroma, primarily pathology confined to the stroma. It's just like Reese-Buechler's, it will stain with Mason trichrome stain. Lattice dystrophy, same gene, except amyloid deposits. And clinically, as the name implies, we have these lattice-like translucent lines within the corneal stroma. You will see characteristic amyloid deposits with characteristic staining with Congo red stain and birefringence pattern. In the past, familial amyloidosis that can involve the cornea, also known as Mary-Toya syndrome, caused by Gelzelin or Gelzelin gene mutations, has been grouped together with lattice dystrophy. This is now separate from lattice dystrophy, TGFBI type, since, with our genetic classification. And the reason why you see this morphologic overlap with lattice is because amyloid here deposits along peripheral nerves. And peripheral nerves run in, branch-like fashion within the cornea. And last but not least here, with TGFBI dystrophies, you can have an overlap with hyaline and amyloid type deposits together, and that's called granular corneal dystrophy type 2, which in the past was called Avellino dystrophy, based on the region where it was initially described in one family. We now identify this dystrophy in many other locales, and you would expect to see here a mixture of amyloid and hyaline deposits. Typically, hyaline granular dystrophy type deposits manifest first, hence the term granular corneal dystrophy type 2. Now, there are some dystrophies that primarily manifest at the level of corneal stroma. Not entirely, but they're grouped with stromal dystrophies. And please excuse my typo, it's not stromal TGFBI, it's just stromal dystrophies. Macular dystrophy, probably the most common stromal dystrophy in Saudi Arabia. Again, autosomal recessive, so more common in populations where you have intermarriage, caused by mutations in carbohydrate sulfotransferase 6 gene, and as the name implies, presents early with these macular deposits, macules in the stroma. Later, these will coalesce and will be associated with edema. What you have here is a defect in ability to link sulfate to keratin. So you have accumulation of non-sulfated glycosaminoglycans in the corneal stroma. Early on, because there is no normal glycosaminoglycan, as you should have in the stroma, it's thin. So glycosaminoglycans are involved in drawing fluid into the corneal stroma. If you don't have normal material, stroma is unusually thin. Later, because this dystrophy actually affects endothelium as well, stroma will become secondarily edematous. So you can see here this glycosaminoglycan deposit in the lamellae, within stromal keratocytes, and also in corneal endothelium. As corneal endothelium becomes defective, it elaborates goutte-like excrescences or protrusions that are reminiscent of Fuchs dystrophy that we will talk about in a little bit. This material will stain with Alcian blue and colloidal iron stains. Note that the epithelium is not involved. The process is in the corneal stroma and in the endothelium. You need to distinguish this from systemic mucopolysaccharidosis. And generally, it may be a challenge to pathologists without clinical background, but to a clinician, it's not a challenge because they will see stigmata of systemic amyloidosis. Here, you will have too much of normal glycosaminoglycan within the stroma. So the cornea is going to be markedly edematous since birth. And unlike macular dystrophy, epithelium is also usually involved. And unlike macular dystrophy, there are no gouttae usually, even though endothelium is also involved. And final dystrophy in the stroma is Schnyder dystrophy, also known as crystalline keratopathy, because these patients have crystalline-like deposits in the stroma. Now, that's a bit of a misnomer because actually only half of the patients will have crystalline deposits. Some will have nebulous lipid deposits that are reminiscent of arcus senilis or inherited lipid storage diseases. Autosomal dominant, ubiquitin A prenyltransferase domain containing one gene is involved. And unlike most dystrophies, it can manifest later in life. And unlike most dystrophies, it can be associated with systemic problems such as hyperlipidemia and cardiovascular disease. So that is something worth knowing. And histologically, pathology is confined to the stroma, where you have this frothy, vacuolated stromal appearance reflecting presence of cholesterol and phospholipids. Sometimes an astute clinician will ask you to do lipid stains on frozen tissue, and that's what they're looking for. So they are trying to get a diagnosis by doing an oil redox stain to confirm Schnyder dystrophy. An astute pathologist may also suggest to a clinician genetic testing, since now we know the underlying mutation. So this is a mnemonic that we teach to our ophthalmology residents that helps them keep in mind the most common stromal dystrophies, what deposits and what stains to do. Note that the last dystrophies are TGFBI dystrophies. Now let's move on to endothelial dystrophies. And again, there are several of them. We will only talk about the ones that we will most commonly see in pathology practice. Fuchs corneal endothelial dystrophy is the most common one, and perhaps the one that all of you will see if you practice eye pathology. Here we can see this corneal endothelium with endosomase membrane with beaten metal-like appearance, reflecting presence of numerous anvil-shaped excrescences at the level of endosomase membrane, known as guttae, surrounded by partially atrophic endothelium that is pleomorphic, so it has abnormalities in shape, loses its normal hexagonal morphology, and polymegathic. It has variation in size. So not only do these patients have loss of endothelium, this endothelium is also functionally abnormal. And that is what accounts for secondary edema in the cornea. There are multiple genes that have been associated with Fuchs dystrophy, and in many cases, patients who do not know genetic defect. The most recent literature tells us that TCG4 gene intronic repeat expansion is found in many patients with Fuchs dystrophy. Patients with early onset Fuchs have mutation in collagen 8 gene, and some heterozygote patients with children who have Chet dystrophy have the same genetic defect as in Chet. We will talk about it in a bit. So this is a beautiful scanning electron microscopy photograph of guttae. And this is a flat preparation that we do in our lab to highlight 360-degree kind of eagle's view of endosomase membrane that is stripped by the surgeon in order to transplant new endosomase membrane for treatment of this condition. You can see these round guttae surrounded by corneal endothelium. Look variation in cellularity reflecting differences in size and shape. And also see, take note that some of these cells have intracytoplasmic melanin pigment from iris. And that is the reason why clinically these guttae look pigmented. This is a cross-section of the cornea where penetrating keratoplasty was done for Fuchs dystrophy. You can appreciate central thickening of endosomase membrane, guttate excrescences. Endothelium is decreased in cellularity, but some cells are still present. Because of functional abnormality of these cells, you have secondary stromal edema, which manifests with loss of artifactitious clefts. Thickened endosomase membrane again with guttae, moderate to severe endothelial cell loss, secondary stromal edema, secondary swelling of surface epithelium, and then ultimately you're going to have extracellular epithelial edema that will manifest as bullae. Because of that, epithelial basement membrane is going to be abnormally thickened. And as epithelial cells slide into the cleft, you will have reduplication with intraepithelial basement membrane formation. Sounds familiar, I hope, right? What I'm describing to you is something that you can see in epithelial basement membrane dystrophy. However, in this case, in bullous keratopathy, the reason for this change is the underlying edema, which in turn is caused by loss of normal endothelial integrity. And this condition is known as bullous keratopathy. There are many reasons for it. To make a diagnosis, you have to look at corneal endothelium and Descemet's membrane. In this case, the reason for bullous keratopathy is Fuchs corneal endothelial dystrophy. In this case, Descemet's membrane is thin, uniform, endothelium is pretty much absent. The reason for this bullous keratopathy could be aphakia, pseudophakia, failed penetrating keratoplastic graft, end-stage glaucoma. To distinguish between these possibilities, you need to pay attention to other subtle details, to wounds, clinical history. So you can see, just remember that surface epithelium can look identical in epithelial basement membrane dystrophy. In most cases, you have traumatic recurrent erosion, neurotrophic keratopathy, or edema that accounts for these particular changes, not dystrophy. And we're almost done here. So congenital hereditary endothelial dystrophy, or CHED, autosomal recessive, SLC4A11 gene mutations have been shown to occur in these patients. Heterozygous mutations have been shown to occur in parents of children with CHED. Histologically, you may either see thin Descemet's with no endothelium and secondary edema, or thickened Descemet's membrane with attenuated endothelium and secondary stromal edema. Posterior polymorphous dystrophy has 3 phenotypes, and in 2 of these, the underlying genetic defect has been identified. The key finding clinically are these blebs and snail track-like lines on posterior corneal surface. And the hallmark histologically is epithelial cells undergoing squamous transdifferentiation, elaborating high molecular weight cytokeratins, desmosomes, and growing in multi-layered fashion. Frequently, Descemet's membrane is multilaminated. So I have alluded to that genetic testing has now become one of the ways to diagnose these dystrophies. It is also important in providing genetic counseling and in prognostication. For example, in TGFBI dystrophies, fine-tuning a genetic defect can give a clinician an idea of how likely the dystrophy will recur in a graft, for example. So any questions before we take a look at an example and then proceed to virtual slide? Anyone? You can put your questions into chat window. Okay, so does OCT have a role in diagnosis? Yes. If we have time, I will show you how the OCT is used. So there is an anterior segment OCT that clinicians will use to highlight for them distribution of opacities and fine-tune their clinical diagnosis. And then that will help pathologists with their differential diagnosis. Do you find Fuchs dystrophy in corneas removed for edema, where Fuchs dystrophy was not identified clinically? Yes. you can. Any other questions?
Could you give us a sense of how common these conditions are? I realize it depends on the pathologist's practice, but are they exceedingly rare? Or, I mean, you mentioned, anyways, can you comment on the
so Fuchs dystrophy is one of the most common indications for surgical procedures. You will see them in either decimate stripping or in penetrating keratoplasty specimens. Extremely common, like see it almost every day. Stromal, and you will see them too if your clinicians are submitting their cornea specimens. So guaranteed. Now, corneal epithelial stromal TGFBI dystrophies depends on your clinician's practice. We usually see them, every couple of months we'll see a case. So for us and for most centers, that's pretty common. In other centers, maybe once or twice a year, but you have to be aware of them because, you need to be able to diagnose them. Any other questions? And did I answer your questions?
Could you comment on pediatric incidence versus
Pediatric?
adult? Yeah, I mean, just
yeah. So Chad, yeah. So we here have a huge referral base from CHAP and from our own clinicians at Wills Eye. So we see lots of pediatric corneas. So we see CHAD, aniridia cases. We see lots of pediatric, like posterior polymorphous dystrophy from our clinicians. In LabCorp or in, general hospital pathology that doesn't have a specialized corneal surgeon base, you may see only sporadically these cases. Most corneal dystrophy cases, in my experience, you will see in young to middle-aged adults, because that's the time when these patients will come to have severe visual dysfunction. So that will necessitate surgical intervention. Conditions like CHAD frequently are handled early because there is rapid kind of early onset corneal edema. So you will more likely to see those in pediatric population as a pathologist. Okay, so now we spoke about dystrophies, right? But I would like to walk you through this case before we jump into whatever time we have left in virtual slides, because that's how we approach these cases. So this is first patient that I'll share with you. This patient is a 74-year-old, know the age, Caucasian man of Italian descent. So I'm kind of trying to throw a red herring of Avellino dystrophy there, who has progressive visual loss over the past year. He has no contributory family history of similar disorders. He was seen by corneal specialists who were considering dystrophies, herpetic keratitis, acanthamoeba keratitis, inflammatory etiologies. The condition progressed and penetrating keratoplasty was done for diagnosis as well as for therapy. Okay. And here we have these deposits in all layers of corneal stroma. And this is histology. So now I would like you to tell me, what are your thoughts? Just based on that. So let's do it fast because I want to show you at least one virtual slide. Anyone? So we see these eosinophilic deposits subepithelially and in the stroma, somewhat reminiscent of the dystrophies that we discovered, but not quite, yes? So anyone, any possibilities here? You can use the chat window, please. Okay, does it look like? Yeah, so it kind of looks like it could be either hyaline, but not quite, not as sharply demarcated or as intensely eosinophilic. Kind of like amyloid, but also not quite, a little bit too sharply demarcated. And that's why you're hesitating. So look, it stains with Mason trichrome, just like hyaline. But again, the shape of deposits is different. Compare this to what we've discussed. It does not stain with Congo red, nor does it birefringe. Okay, put on your thinking hats on, think of kidney. What could this be? So this stains with IgG, and this stains with lambda light chain. It does not stain with kappa or other heavy chains. This is immunoglobulin deposit on the cornea. Classic ultrastructure, 7 nanometer filaments, 10 nanometer periodicity. You can also see immunotactoid type deposits that you see in the kidney. And this pretty much implies paraproteinemia. So your job as a pathologist is to ensure that clinician refers the patient to hematologist oncologist for evaluation of underlying plasma cell myeloma or MCAS, which is what this patient had. This is classic paraproteinemic keratopathy. And I think this is probably most important. If anything, this is the most important thing I will share with you, is because as our population gets older, we see more and more of these cases. And clinicians will think of dystrophies. And you, if you don't know what you're dealing with, will think of dystrophies. And all this time, this patient will actually have underlying malignancy or MGUS that can convert to malignancy, as you know. This is an example how another older patient presented with something that looked like lattice or Rees-Buechler's dystrophy. And this, you see, this is the anterior segment OCT that also shows deposits beneath epithelium reminiscent of Rees-Buechler's dystrophy, which was the diagnosis from the clinician. The clinician examined family members and they were normal. Note, unlike in Rees-Buechler's dystrophy, Bowman's layer is not destroyed. Deposits are subepithelially. Kind of look like thickened basement membrane, but not quite. Stained with PES, just like basement membrane, but also stained with trichrome, unlike basement membrane. And do not stain with Congo red, will stain with immunoglobulin chains. Now, these can be tricky. So, if you have an EM is a nice way to diagnose these. Or, it's a diagnosis of exclusion. You can do TGFBI genetic studies, and then you can say, this is what it's immunoglobulin. Even if immunohistochemical studies do not work, suggest that the patient undergoes systemic workup. Okay, so that is the main point I wanted to make with the illustrative example. Any questions before we move on to a virtual slide?
If anybody has questions, you can use the chat, or you can unmute yourself.
All right, so has anyone had an opportunity to review slides? And if yes, were there specific cases that you would like me to go over? Because I don't think we will be able to go over all of them in the time frame provided.
I think you can probably select.
Okay, so why don't we look at this one first? So here we have a cornea, full thickness cornea, in a patient who has decreased vision. Usually you will have decreased vision cornea, okay? So any thoughts, when we approach these cases, we always want to look at the corneal shape, at the corneal thickness, and then a little bit closer, okay? So any thoughts on what we're seeing here? Anyone?
There's some stuff in the chat.
Okay, amyloid deposition. So it's excellent. The last one, keratoconus and amyloid. That's exactly what this is. Perfect. So what we're seeing here is central stromal lactation, right? And because Bowman's layer is right there, everyone can see the arrow, right? So central stroma is thin. There is subepithelial amyloid deposit. So we're dealing with an ectatic disorder of the cornea that causes thinning of the stroma. You can actually see here and there dehiscences in Bowman's layer that we expect to see with keratoconus. And secondary amyloidosis. Very good. So Congo Red will confirm that this is amyloid. There is nothing that you need to do here. Don't even think about dystrophies. Secondary localized amyloidosis in a traumatized eye. Following, contact lenses and erosions in an eye with keratoconus. Okay, any questions before we move on to another case? Okay, so why don't we now look at case 2? Okay. Tell me, what kind of surgery was done in this case? So as we look at these pieces of the cornea, does anyone know? So this cornea came out in 2 pieces, anterior cornea and posterior cornea. There is no Descemet's membrane. Instead, you have these empty-looking vacuoles in posterior stroma. So this is an example of deep anterior lamellar keratoplasty that is also most commonly done for keratoconus. But in this case, it was done for the dystrophy that manifested itself primarily in the stroma. And these empty spaces are caused by air and viscoelastic dissection to create a plane, to remove anterior part of the cornea and leave Descemet's membrane and endothelium intact. So any thoughts about what kind of dystrophy this is? Kind of looks like granular, right? But there are also these deposits that look a little bit smudgy. So it's granular, but the question is it granular type 1 or is this granular type 2, or formerly known avellina? So for this particular case, we have performed EM and stains, okay, for academic reasons. Can you see how you have a mixture of deposits, congophilic deposits and Mason trichrome positive deposits? So this patient actually had avellina dystrophy with 2 types of deposits present, and with electron microscopy, there was a mixture of amyloid and paracrystalline deposits. Very good. All right, so let's see how much time. So we have time for one more case, perhaps. Let's look at case 3. So any thoughts about what you're seeing here? Anyone? So there are deposits here. Can you appreciate how these deposits are subepithelial? So what are you thinking? What are your thoughts? Anyone? Excellent. So you have correctly identified that this is a penetrating keratoplasty. Deposits are occurring along the suture tracts and graft-host junction and subepithelially. Now, I will tell you that this is not amyloid. It's too eosinophilic and too sharply demarcated. So this is actually granular corneal dystrophy recurring in a graft. So wound of prior penetrating keratoplasty here is very helpful because otherwise a possible differential diagnosis would have been Reese-Buechler dystrophy. If it were amyloid, a possible differential diagnosis would have been gelatinous droplet dystrophy. In penetrating keratoplasty, typically deposits appear along the graft-host junction and subepithelially, because remember how I said epithelium is the major source of keratoepithelium, and it's the recipient cornea epithelium that populates donor cornea. So you have continued production of mutant keratoepithelium by the recipient epithelium, and it's primarily in subepithelial location. Okay, any questions on this case? Anyone? And any questions in general, because I think we only have 1 minute left. Would be nice. Okay, of all the virtual slides, what I can do is I can actually provide for you answers, if that's okay, and somebody will distribute.
Yeah, we can definitely do that.
I mean, they will have access to the slide box, right? So
Yep.
I can, if I deposit the answers in the slide box, you'll see them, right? Yeah, I'll do that.
Yes, and actually these were not available before the session, so I apologize for that. If that's why people hadn't had the chance to review them in advance.
Okay, sounds good. So I will provide that information. You know where to find me. If you have any questions, just reach out to me. Okay.
Sounds good. Thank you so much, Dr. Milman.
Okay, you're welcome. Bye-bye.
Thank you, Dr. Milman. We have just a few closing announcements.
Okay, so I'll stop sharing. Yep.
Sounds good. Thank you again for joining today's AANP Teaching Rounds presentation. We'd ask that everyone take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PATH LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. We can also post the questions and answers. And thank you again to Dr. Milman for an excellent presentation. This concludes the session for today. Thank you, everyone.
Thank you again.